Good afternoon. I'm Dr. Linda Ehrlich-Jones, and I'm here to welcome you to the webinar entitled Using Client-Centered Practice and Patient-Reported Outcomes. Our speaker today is Dr. Joy Hamill. Dr. Hamill is a professor in occupational therapy and disability studies at the University of Illinois at Chicago. She is a nationally and internationally recognized leader, scholar, and educator in the areas of community living and participation disparities with people with disabilities, as well as community-based participatory research. Dr. Hamill was instrumental in developing the 4-module series on measuring rehabilitation outcomes that this webinar comes from. We would like to acknowledge the generous contributions of the Retirement Research Foundation through their grant entitled Enhancing Clinicians' Ability to Assess, Monitor, and Appropriately Treat Older Individuals Undergoing Rehabilitation, and the National Institute on Disability and Rehabilitation Research for the Rehabilitation Research and Training Center on improving measurement of medical rehabilitation outcomes. In addition, we would like to thank our collaborators who have helped build the Rehabilitation Measures database. Their contributions have made the RMD a trusted resource for information regarding the use of outcome measures. At the end of the webinar, if you could fill out a course evaluation, that would be great. And also to let you know that there are no continuing education credits associated with this webinar. And we'll be hosting a one-day course on measurement on July 25th, 2014, here at the Rehabilitation Institute of Chicago. So please save that date. It is my pleasure to introduce Dr. Hamill.
Thank you, Linda, and welcome to this webinar on patient-reported outcomes. What I'd like to do is talk about 4 different objectives within this webinar. The first one is just talking about what is a patient-reported outcome. What's the theory base behind it and the research behind it? How do we define them and how do we assess them? Secondly, I'd like to focus in on providing you with some examples of patient-reported outcome assessment measures that you could use in your practice. Third, I'd like to then compare patient-reported outcomes to clinician-rated observable performance assessments and talk about what do you get from a patient-reported outcome as compared to that clinical observation, and are patient-reported outcomes valuable and worthwhile for the extra time to do them. And then fourth, I'd like to focus in on how you can use patient-reported outcomes across clients and across programs to document outcomes and show your treatment effectiveness. So let's start, first of all, with just focusing in on what is a patient-reported outcome. As a clinician, as an occupational therapist, if you would have asked me when I first became an OT 20-some-odd years ago, what self-report meant, I would have said it's subjective, it's soft research, it's touchy-feely research. But increasingly what we're seeing now is an increasing body of research that shows patient-reported outcomes are equally valid and important outcomes to be able to measure. Increasingly we're seeing it within the literature as how to use these patient-reported outcomes and their validity and their sensitivity. When you're looking in the literature, you might actually see it referred to in lots of different ways. Sometimes they're called self-report, sometimes subjective. There's a whole body of research on client-centered practice, goal setting, and outcomes. From the disability community, there's also a body of research on consumer-directed outcomes and programming. But in the research most commonly now, they're referring to it as patient-reported outcomes, or PROs. PROs are based on something called a client-centered philosophy, which is very strongly based on the need to listen to the voice of the client or the consumer in what's most important to them, and have that drive how you set goals and how you intervene during your treatment sessions. So that in essence what you're creating are clients that are informed consumers of their own care, and that they can advocate for that care long after their treatment session with you. Client-centered philosophy is based on a number of basic assumptions. One is that the client or the consumer knows themselves best and what's most important to them. Another is that the clients each are different and unique, so it's important to spend some time figuring out what, again, is most important to them as individuals. And then third, it's based on that optimal client functioning occurs within a supportive family and community context. So it's really quite important to be able to create an environment that is supportive for a person to give voice to what's important to them. Why would you use a client-centered philosophy? Well, increasingly the research is showing that clients who set their own goals achieve better outcomes than those who do not. And this can be due to a lot of different reasons. First of all, setting goals focuses a person's attention and directs them towards that specific effort. Another reason is that clients who set goals are establishing challenging but realistic goals that then lead to greater effort, a greater persistence, because it's something that they're invested in. Challenging goals also leads to higher performance versus just encouraging the person to do his or her best. And setting the goals prompts the person to apply or develop his or her own skills to achieve the final goal or outcome. And this is based on Bandura's self-efficacy theory that says when you're able to set client-centered goals, those then relate to outcomes and behaviors, and people are more likely to reach those goals. And then finally, goal achievement also is requiring ongoing feedback that recognizes a person's progress towards that goal. So this talked about what we know from a client-centered philosophy, but increasingly now we're seeing a whole body of research called patient-centered outcomes research that takes these self-reports of the patient or the client and begins to tie them to outcomes and documentation of outcomes of our interventions. So patient-centered outcome research focuses again on if you create these informed consumers that are invested and involved in their care and reporting on what's going on during it, that they have better outcomes and that you can begin to track those outcomes and see which treatment is most effective and for whom. So let's start with just looking at some of the definitions for what a PRO is defined as. So first of all, starting with PRO itself, a patient-reported outcome, is basically a self-report of the status of a client's health condition that comes directly from the client. And the reason we would use a PRO is to be able to assess an individual's status at a certain point in time and to be able to set client-centered goals with them. The second term that's used is a PROM, or a patient-reported outcome measure. And when we're using a PROM, we're now using a validated assessment or instrument or scale to be able to assess the client's perceptions. And the reason we'd want to use a PROM is if we want to begin to document individual outcomes over time. And then finally, the last term we'll talk about today is the PRO-PM, or Performance Measure System. And this is usually an online system that gives you access to a number of different items on self-report and allows you to aggregate that data across people so you can begin to document service and program outcomes across your clients, and you can document impact and effectiveness of your treatment and programming. So let's start with looking at some common used patient-reported outcomes. And in specific, I'm going to focus on outcome tools that look specifically at a patient's perceptions of their activity and their participation. So starting with the first tool, which is the Canadian Occupational Performance Measure, or the COPM. The COPM is a patient-reported outcome that allows a client to identify issues and set goals in 3 areas of functioning: self-care, productivity, and leisure. What you're seeing here in this slide is an actual summary assessment for a client that we're going to look at throughout this webinar. His name is John. John is 62 years old. He had a stroke, and he's being discharged from inpatient rehab in the hopes of returning home and to the community. So you're seeing his COPM score at discharge right now. What's nice about the COPM is it allows you to really get a good client grounding and perspective of importance. So the first thing the COPM asks you to do is qualitatively interview the person and ask them, what does a typical day look like for you? As they're talking to you, you note down what activities they're involved in. That could be self-care activities, could be productivity or work or learning activities, or could be leisure activities. And what you're seeing here for John is that he's identified many activities under self-care and productivity but nothing under leisure, which tells us that there might be some gaps there right away. After he's identified what a day looks like, we ask him to rate the importance of these activities to him on a scale of 1 to 10, with 10 being the most important. This also gives us a good self-report measure of what's most meaningful to John, what he most wants to work on. Once we've done that initial interview then, the COPM guides you through asking the client to then say across all these different things in your life, pick the 5 most important things you want to work on right now. So here's where we start doing patient-centered goal planning. And you can see for John here that he picked issues like communicating with his family, going back to work, dressing, and driving. So he kind of went across the 3 areas of self-care, productivity, and leisure. Once he's done his 5 most important goals, we ask him to self-report on 2 additional areas. The first is we ask him to self-report on how well does he think he's performing these from his perspective. And then second, we ask him how satisfied is he with that performance, again using the 1 to 10 scale. So we get 2 different kinds of self-report reads for him on performance and satisfaction. We also get summary scores across his 5 goals in both of these areas. And then in the future, we can reassess whether there's been change over time in both of these self-report scores. So we can begin to do some outcome analyses here as well. What's nice about the COPM is not only is it an assessment tool that you can use that's client-centered, but it's also been validated as a PROM measure. Over many years across thousands of clients in Canada, the COPM is used with all the clients in the healthcare delivery system. So we have lots of data on that. It's also very widely used in the United States and in the European Consortium. And it's been validated to show changes over time in goal attainment and performance and satisfaction from the client perspective. There's also additional research being conducted on the COPM to see if you could use it to compare to a family or significant other's self-report of that client's performance and satisfaction as well. A second example of a patient-reported outcome measure that you could use in your practice is the activity card sort, or ACS, developed by Carolyn Baum. And what you're seeing here again is a summary score sheet of John's scores on the activity card sort. The ACS is basically a set of 90 cards that each have a picture on them of somebody doing a task or participating in a task. And so when you're administering it to a client, not only do they get the words of the task, but they get that extra photo visual cue of what's going on as well. And what you're asking them to self-report on are a couple of different things. The first thing you ask them is, did they used to do this activity before they had their disability or before you saw them in your program? And then you ask them, since then, since your illness or your injury or disability event, are you continuing to do the activity, which would be a good positive outcome, or are you doing less of it or have you completely given it up? Both of which may be negative outcomes in that the person's letting go or reducing activities. These may be the kind of activities from the self-report that you may want to work with John on to prioritize and say which are most important for us to work on in therapy so you can regain some of these. The third patient-reported outcome measure that I'd like to share with you is the Community Participation Indicators, or the CPI assessment tool. This is a tool that I was involved in the development and validation of, and that was based on the voice of people with disabilities, talking about what was most important to them in terms of community participation. And the tool actually is available for free and is available in your handouts that you can use as part of the Rehabilitation Research and Training Center on Rehabilitation Outcomes. So let's take a look at the CPI a little bit. The first part of the CPI actually asks the person to self-report on several areas of participation. What you're seeing on this slide is social relationships and participation in them. And we ask the person to self-report in several different areas. The first thing we ask them is how often are they doing these, the frequency. The second thing is, how important is it to you? Do you even care about it? Is it something you want to work on? And then the third thing we ask them about is to self-report on their satisfaction. And the way we're asking about satisfaction is, are you able to do it when you need to or want to? And so we see here for John, since his stroke, that there's many different social relationship activities that are very important to him. However, he's not that satisfied with many of them, and there's many opportunities here to put these into treatment goals that you could work on. In addition to these social relationship items, the CPI also takes the person through the same set of questions on home management, community participation, and work and productive participation as well. The second part of the CPI, though, gets at a different kind of self-report, and that is it focuses on a concept called enfranchisement, which you may also be heard and talked about as community integration, social integration, and social capital. These are values that were identified directly by people with disabilities in focus groups as indicators of whether they felt they were fully participating in their community or not. And it's a 48-item scale that has been validated to be able to measure enfranchisement from a self-report. So for example, with John, we can see that there's some areas that he doesn't feel particularly enfranchised or integrated or included with. For instance, he's not able to go out and do things and have fun in the community. He doesn't feel like he has a voice or he's able to offer anything back to the community. And he also has issues with saying there's a lack of access to information now that he has a stroke about how he'll get around in the community after rehabilitation. All of these are indicators of whether he's enfranchised and included in that community. So we've looked at some patient-reported outcome measures. The second part of this, what I want to talk about, is how do self-reports compared to clinical performance observations? Do you need to do both or not? And what do the two offer to you when you're assessing them? So what I'd like to do is continue with the John example here and focus in on two different examples. The first one is fall risk, and the second one is safety and judgment. Two outcomes that are incredibly important for people with disabilities and older adults in relation to staying in the community. So let's start with fall risk, first of all. On the left on this slide, you see one of the most commonly and widely validated assessment tools for clinically observing fall risk, and that is the Berg Balance Scale. That has 14 items, specifically performance items that the client does, and is administered by a clinician, typically a physical therapist or an occupational therapist who's been trained in its administration. On the right, we see a PRO, a patient-reported outcome tool, called the ABC scale, or Activity-Specific Balance Confidence Scale. This assessment has 16 self-report questions that ask the client how confident they are in maintaining their balance and remaining steady when they participate in everyday activities. So let's take a look at John and see how he scored on both of these. The first thing I'd like to do is show you a video from the Berg Balance where we're asking John to be able to pick up a slipper from the floor without losing his balance or falling. Okay, so you can see from this video, even though it's a very short clip, that John was experiencing some issues and that, in fact, he wasn't able to perform that activity from a clinical rating. But now let's look at what his self-report is on the ABC scale. One of the first questions we ask John is how confident he is in bending over and picking up a slipper from the floor. And we see here that John rated his self-confidence at 90%. So he's very highly rating his confidence in relationship to falls and doesn't feel that he's at risk for falls. However, on the ABC, we do see that John is aware of some areas where he might be at high risk, such as standing on a chair and reaching for something or walking outside on icy sidewalks. So what can we see from these two different kinds of assessments? Well, first of all, we can see that there is a mismatch between John's confidence in his or her balance and his actual abilities. But we also see from the self-report that John does have some self-awareness of particularly threatening activities. So we can start there by asking him to describe what makes these particularly threatening activities risky for him. Why does he think he might fall there? And then we can play the video back to John of what actually happened with him when he was doing something less risky and show that he was overestimating his ability and that he was having some issues there, and begin to use that as our starting point for a client-centered goal to work on. Since falls are such a common patient-reported outcome of use in clinical therapy, I've also provided you with some other additional resources on patient-reported outcomes specific to falls. One of the most commonly used, widely validated self-reports is the Falls Efficacy Scale-International, or the FES-I, which has 16 self-report items that a person rates on how concerned they are that they might fall while doing these activities. I've also provided in this slide two additional research that has said that maybe you don't even need to do the full 16-item patient report, but instead there's research showing that just asking one or two self-report questions are highly predictive of whether a person is facing fear of falling issues, and those correlate then to whether a person actually might experience a fall or have activity restrictions in their life because of their fear of falling. In this second case then, what I'd like to do is now focus on the example of looking at cognitive executive functioning, particularly safety and judgment in this case. And we're going to use an assessment called the Executive Functioning Performance Test, or EFPT, which is both a self-report and a clinical observable test. And we're going to show you this video that shows John performing, first of all, the self-report to say where he thinks he is at, and then asking him to perform a medication management assessment. Okay, so you can see on the EFPT a lot of information about John. First of all, on this slide, it shows you the self-report questions that he answered. And the first thing to note is we did ask him about whether he felt he was able to take medications on his own. And he did self-assess himself to say that he would be independent in doing so. However, when we look at what actually happened when he was asked to do that medication management, we see that there were several areas that John did require some assistance with. He was actually independent in starting and stopping the task, but he did require some verbal guidance, specifically related to judgment and safety. And in one case, he actually did require gestural guidance to the pill bottle to actually figure out how many pills to take and what he needed to do that. So we see here in the clinical observation that there were some issues that John faced. So what's nice about the EFPT is it gives you a summary sheet where on the left we can see the person's patient-reported outcomes, how confident they felt they were. On the right, we can see their actual performance from a clinical perspective. And then at the end, the EFPT gives you a summary clinical implications section where we can say across this information, do we think that there are any self-awareness issues that might affect John's judgment and safety? And in this case, we can say, yes, there were some issues in that he underestimated his need for help. So you can see from these two examples that there really is a reason to look at both patient-reported outcomes and clinical observable performance outcomes. In this study by Robinson, which was done in the American Journal of Physical Therapy, they also did some research to see whether both were needed. And what they found is that there was a weak correlation between patient-reported outcomes and clinical observable outcomes, and that indeed they were measuring two different kinds of things. That the clinical ratings were measuring the performance or the doing, and that the patient-reported outcomes were measuring a person's sense of self-efficacy. So their recommendation is it's important to administer both when possible in order to make the most accurate determination of where the person is at, and also to tailor your treatment or intervention to influence self-awareness issues with them. So what are some of the added values then of using patient-reported outcomes? Well, first of all, we can see through the videos that it's a good way to assess self-awareness. It also lets you assess confidence or self-efficacy, which we know from Bandura's self-efficacy theory is then predictive of and can lead to actual improved behavior or performance. They are also easily translatable then into client-centered goals, so you can measure changes in these patient-reported outcomes over time. Another added value of a patient-reported outcome is that it allows you to assess readiness to change, or what's called patient activation. And what you're seeing in this slide is some sample items from the Patient Activation Measure, or the PAM, which was a self-report assessment that assesses where the person is in terms of being able to manage chronic conditions in their everyday life and take care of their health. And also allows you to say, what phase are they in? Are they just starting and even thinking about this? Are they strategizing it and starting to use some strategies and work on it? Or are they fairly resilient and know how to manage their health even under, say, emergency or crisis situations? So readiness to change is yet another patient-reported outcome benefit. And then finally, an added value of patient-reported outcomes is they allow you also to assess global and specific changes both in overall quality of life and in life satisfaction. As an example of this, here is the World Health Organization's WHO-QoL Brief Patient-Reported Assessment, which looks at, first of all, global quality of life and satisfaction, and then follows it with a specific set of items related to self-report on quality of life of physical health, psychological health, social relationships, and whether the person feels they have a supportive environment. When you're doing quality of life assessment as a patient-reported outcome, you need to know that there's hundreds of different quality of life tools out there. So it's really important to look for quality of life assessment tools that were validated for your target population. And the other thing to note is you want to choose quality of life assessments that actually ask for specific quality of life in areas that you think your treatment is most geared to impact. So only asking about global quality of life may not show any changes in outcome for a person because there's so many other things affecting their global quality of life. However, if you ask specific items related to quality of life, such as their psychological health or social relationships, you have a better opportunity to show whether your treatment influenced outcomes over time. And finally, let's look at some common misperceptions about patient-reported outcomes when we compare them to clinical observable ratings. Some of the most common misconceptions about self-report is that they're not as valid, they're not as reliable, and they're more subjective than the clinical ratings. However, I think you've known from the examples we've already shown that it's not that a self-report is only subjective, but that both of these are measuring different things, one performance and one an objective rating of self-efficacy. We also know from the research that patient-reported outcomes are not necessarily less valid or less reliable. Validity and reliability are in large part dependent on who is doing the assessment and whether that clinician has been trained correctly in how to do it, and whether the assessment tool itself has been validated for validity, reliability, and sensitivity. So you want to select patient-reported outcomes that have been validated for use with your target population. So how do you do that? There's thousands of instruments out there. You don't have a lot of time as a clinician to be able to go and try to hunt these down. Well, one way to find validated patient-reported outcome assessment tools is to use a resource called the Rehabilitation Measures Database, or the RMD. This slide shows you the Rehabilitation Measures Database. It was developed by clinicians for clinicians as an easy way for you to find validated assessment tools that you could use to measure outcomes. When I get to the RMD, I can type in any term that I want to search on to find instruments, such as quality of life. I hit the search item, and the RMD will then begin to list for me a number of different assessment tools that look at quality of life. If I click on any of these assessment tools, I begin to get a review that tells me what is the validation measures of this instrument. Is it valid? Is it reliable? Can it show minimally clinically significant differences or not? And who is it valid for? It also tells me how to get the instrument, how much it costs to do that, and specifically what kinds of target populations it was normed on. Another outcome tool that you can use as a resource is the Stanford Patient Education Research Center. This was in large part developed by Kate Lorig as part of the Chronic Disease Self-Management Program, and this website links you to a number of patient-reported outcomes that look at self-management and self-efficacy related to managing chronic diseases and other disability and long-term conditions in people's lives. And then finally, another resource that you have available to you is what is called a PRO-PM, or Performance Measure System, and that is the PROMIS system. PROMIS stands for Patient-Reported Outcome Measurement Information System. PROMIS was developed as part of an NIH, National Institute of Health, roadmap initiative, which means that what they were trying to do is go across all the different institutes to be able to develop a self-report computer-based assessment tool that would be able to be used across different clients and across different diagnoses. So when we're measuring outcomes in different research studies, we can actually compare those outcomes across the studies. Since then, PROMIS has become a clinically relevant database of self-report tools as well that you can use to measure how well your clients are doing from a self-report perspective. And you can compare then the data of the individual client to that of other people in the database of the same age and gender. One of the resources under the PROMIS website is something called the Assessment Center, and this is where all the self-report measures are housed. So there's self-reports related to physical health, to mental health, and to social health. And you can customize which of these that you want data on. If we go to the assessment center, we can actually see how this happens. So one of the things it allows you to do is to put in data of an actual client and see how they do on these self-report measures. Once I click on that computer-adapted test, I can tell it which self-reports I want to look at. For instance, with John, I want to assess depression, fatigue, and satisfaction with social roles. It asks me to enter his age, which is 62, and select his gender so we can compare him. And the assessment center will actually take me through the self-reports with John, and he can actually tell me how he feels about each of these items. So I can begin to look at his level of depression first. And then I can look at his fatigue and self-reports of that, which we know for John has been an issue. And then we can look at John's self-report of his satisfaction with his everyday social roles in his life. And we know from the COPM and other self-reports we did that these were particular issues for John. Once we finish the administration of the self-report, the assessment center actually generates a full outcome report for you. So you can begin to see how John compared to a sample of people in his age range and in his gender. So we can see for John that, for instance, that he has some issues related both to depression, fatigue, and satisfaction, that he is not performing and is not satisfied as much with it as the majority of the population. So all of these would be sample areas that we could work on then in crafting client goals with him. PROMIS also links you to several other specific resources that might be of interest with you related to patient-reported outcomes. For instance, there's an initiative called NeuroQual, and this is a separate research project that uses the PROMIS items but has validated them specifically and added more related to them to be used with people with spinal cord injury, traumatic brain injury, and stroke. It also links you to the NIH Toolbox, which is an objective set of performance measures that you can do online on the computer along with some self-report items. And then it also begins to look at other patient-reported outcomes and tell you how your client would score if they were using the PROMIS items themselves and how they look in relative to that age and gender. This is a project called Rosetta Stone, which is an ongoing and relatively new project that begins to say there's lots of different patient-reported outcomes here. What we need is a way to crosstalk, so I can compare my outcomes on one assessment to another equally valid assessment, say of quality of life. Rosetta Stone is an initiative that allows us to do that crosswalk. And then finally, I want to leave you with another important resource here, and that is PCOR, the Patient-Centered Outcomes Research Institute, which is very new, relatively speaking, at NIH, and has only been around for a couple years, but is now a national institute that is focused on and dedicated to looking at patient-centered outcomes and reporting of them and validation of measures to report them, as well as patient-centered outcomes research, that if we use these client-centered techniques to be able to see what's most important, do they then result in better health outcomes for people with disabilities and other groups such as older adults? So I highly recommend that you visit the PCOR website and begin to see all the different assessments that it connects you to, but also the latest evidence on why patient-centered outcomes research is so important. So just some take-home summary messages from this webinar for you to get. One reason for integrating patient-reported outcomes into your outcome planning is at an individual basis to be able to show client status at specific points in time. So it allows you to look at predicting individual client recovery, to assess client readiness to change, to document client outcomes and change over time, or to more proactively do discharge planning, order needed equipment or supports they might need in the community following the rehabilitation, or to make referrals to other professionals. Additionally, you might want to consider using patient-reported outcomes on a population or a program level to be able to show outcomes across clients, to be able to predict recovery and plan treatment for your program, such as which course of therapy would work best for this type of client. It also allows you to begin to measure changes in outcomes over time across your program, so an impact evaluation or a satisfaction evaluation of how satisfied consumers are with the services that they received. It can also be an important indicator to looking at cost benefit. So you may already be looking at what the costs are of delivering your services or therapies, and you might already be looking at functional outcomes related to them. What a patient-reported outcome allows you to do is further look at benefits from a patient perspective. And then finally, patient-reported outcomes can help you to identify population-level disparities in healthcare. For instance, some of the research that I'm involved at is looking at, for people with long-term disabilities post-rehabilitation, are they facing certain disparities in terms of their ability to participate? And does that have indicators for us on what services should have or could have been done during rehabilitation or should be provided within the community for them? This concludes the seminar on patient-reported outcomes, and I'd also like to again acknowledge our sponsors for this and also point you to that this webinar is just one module in a series of 4 modules on measuring rehabilitation outcomes in your everyday practice. If you're interested in participating in evaluating the rest of the modules and you want to see them, please contact myself or go to the Rehabilitation Research and Training Center's website for more information. Thank you for your participation.